All right, we have a few more joining, but we are right at 2 o'clock, so we'll go ahead and get started. Welcome, everyone. I am Angie Vera, the events manager for PERC and Opti-Port. It's my pleasure to be a part of the team bringing you today's virtual session on managed vision care. Due to the large number of people on the call, everyone will be muted, and we do ask that you utilize the chat box for any questions or comments, and we'll have time at the end to go through those for you. So huge thank you to today's sponsors, Marcolin Eyewear and Design Eyewear Group. We certainly appreciate their continued support. All right, so moving things along to our speaker, Dr. Jason Ortman graduated from the Ohio State University College of Optometry in the year 2000 and completed a residency in ocular disease at the New Mexico VA Medical Center. In addition to primary care, Dr. Ortman enjoys fitting specialty contact lenses and specialty contact lenses and ocular disease management. He earned his board certification from the American Board of Optometry in 2013. He is the owner of Black Diamond Eye Care, a 6-doctor, 2-location practice in suburban Denver. And Black Diamond Eye Care has been recognized as the Business of the Year by the Castle Pines Chamber of Commerce in 2012 and once again in 2022. Black Diamond Eye Care has also been honored with Cooper Vision's Best Practice Award in 2017. Dr. Ortman is active in the Colorado Optometric Association, where he serves as a trustee and a member of the third-party executive committee for the American Optometric Association. And in 2010, he was honored as Colorado's Young Optometrist of the Year. In 2018, he served as the his wife, Lisa, and his children, Caroline and Josh. So it's our pleasure to have Dr. Ortman speaking with us today.
Hello and good afternoon, everyone. I appreciate you taking time out of your day to join us. I'm excited to speak to you about some practical strategies in managed care, kind of an update to the lecture I gave. I know that many of you were at the Elevate conference in April in Atlanta, Georgia. This is kind of an update with certain things. I know there's some new people that haven't been on it. I always start this type of lecture with a couple of different, the same type of beginning. These are the topics I really want to discuss in today's webinar. First of all, provider manuals and related documents and how it's important in managed care and managed vision care. Plan updates, talking about audits because those are a hot topic right now, and then language assistance services for members. These are all how they're related to managed vision care and managed care for commercial and government insurance. One thing I want everyone to note is that the information is dynamic. When you talk about managed care, what works today doesn't always work tomorrow. Insurers like to change their policies, change how they pay for things, change their reimbursements, and change their requirements and deadlines for every practice. They do it sometimes. You could get notices every month from insurers, every quarter, every 6 months, or sometimes every year. The information that I accessed, that I looked up, was really accurate up when I updated and did this lecture to June 27th. So, and most of them give you some time to kind of look over those changes. Parent information guidelines and coverage is subject to change. I encourage all of you to refer to the insurer's provider manuals, their website, and provider updates that they may send to you via email or snail mail for more details, changes, and exclusions. Well, just like my mom used to tell me when I was a kid, instead of just doing something, read the manual first. It's real important to read those provider manuals before and read the provider manual updates when they happen, because if not, you're going to get yourself in trouble. And you're going to wonder why you weren't paid. With changes, certain codes aren't paid like they used to. For many of you know that modifier 25 is a prime example. Another prime example that for medical insurances that have, like, for example, if you have an E&M code and surgical code, modifier 25 has become under more scrutiny by the major medical insurances. As you may know, that IMED a year ago changed its medically necessary contact lens reimbursements, where you have to send your charts showing specific tests and requirements before they will pay a medically necessary contact lens benefit. If you didn't read those changes when they happened in June 2024, you got a lot of rejections from IMED. And I'll talk a little bit more about that later. The provider manuals, obviously, and provider email updates produced by the insurers provide those latest policies, providing benefits for each of the medical insurances and vision care plans. Please read your manuals when they are updated. Failure to do so will lead to frustration. A provider manual is actually technically an extension of the provider contract. So the insurers have to give you notice to changes in that provider manual and changes in the contract. That varies by state. Most insurers will give you 90 days of notice for that. But for example, in Iowa, it's only 30 days. They only have to give you 30 days notice of a change in the contractor manual. In Colorado, it's 90 days. Your state may have different laws. Typically, insurers want to kind of be uniform. So I think in most cases, they give you 90 days. But I've seen in the past where they've only given 30 or 60 days before they change policies for providers. Time to update. Plans can update with that little notice. And if you as a provider or the biller don't understand that, you have a right to choose to accept those terms, negotiate for different terms, or terminate your participation with that plan. The key thing, especially obviously, if a plan is becoming laborious, more difficult to get paid on, or they're dropping reimbursements, you can call and try to negotiate. That's your right. If you're happy with the terms of the plan and the changes, that's why they have to give you 90 days notice of a change. So you have the ability to decide whether you want to continue taking care of that plan, adding that plan, dropping a plan, etc. And just because you're a plan, insurers like VSP or IMED or the major medical insurance come up with new plans all the time. For example, VSP started doing more VSP Advantage plans in the last couple of years. Now, if you have those non-standard plans that don't have the reimbursements like they were before, or if they changed and you don't like the new reimbursement structures, they give you an ability not to accept that plan. But a lot of that depends on you reading and understanding when those plans come out. I wanted to kind of first talk about VSP. One thing that happens commonly, I was talking to some folks at VSP. I do some consulting work for them as an ambassador, so I want to make that clear, is you got to make sure your practice email is updated with VSP. What happens a lot of times that they say, we send the emails out, but think about it. A provider could be contracted 10 years ago, 15 years ago, and 20 years ago. It may have had their office manager do all the contracting and submit all the practice information to the plan. Well, if that office manager who is in your office 10, 15, 20 years ago, when you had an AOL account or a CompuServe account, really isn't there anymore, that email goes to oblivion. So I think it's really important that the provider, using an email address that they know that they can see all the time, the practice owner, or a general email box that's constantly monitored by the practice owner and the practice manager, that's how you'll get that information. Many offices, again, have those old emails set up, and you would never know if changes in that plan are coming, or those 90-day notices are coming, or those whatever, and even new offerings of the plan. VSP does send provider network updates, network provider updates, plan updates, and other important changes through its provider email. They rarely send a snail mail for that anymore. So, for example, providers during the COVID, they sent an email out to providers to get some COVID relief from VSP, but a lot of people didn't. You had to sign up for it and attest to it to get the money, but there were people and practices that never got it because they never looked at that email, and they were literally leaving money on the table. VSP has also made a focus this year, and this is something, especially since April, I've noticed that a focus this year to educate their provider network on how to apply and submit essential medical eye care benefits. These benefits, the essential medical eye care benefits of which I spoke on in April, include over 60% of the VSP membership has them. And in also coordination of benefits, 90% of VSP plans have coordination of benefits. What happens is VSP has on its website under VSP Learning or Premier Edge Learning and Training, you can learn how to submit medical and coordinate those benefits with the vision plan VSP when they have that. And also coordinate refraction only benefit, not refraction, coordinate benefits for the refraction copay up to the VSP allowable for coordination of benefits. It's real important to go on VSP Online, Premier Edge and Training to look at that. But they're also doing live events and webinars. You could contact your VSP state ambassador, and that's on the VSP website, or your VSP Global Business Development Manager to request a meeting in your state or to have one of those group events in your state. But they're also having a webinar on October 8th, and I gave the link there to ask the expert about the essential medical eye care benefits. Every practice should be doing this when they have patients who have both medical and vision issues, and you're seeing them in exam. For example, your diabetic exam. VSP will pay for Optos on all diabetics when they have essential medical eye care, and whether they have retinopathy or not. They will pay when you're not on the for additional testing, for example, OCT, visual fields, etc. If you're not a provider on the medical plan, for example, if it's an HMO that doesn't allow you to be a provider for. So it's real important to check those out and really become aware of those essential medical eye care benefits and coordination of benefits. It could allow you to earn more money per claim. That's the key thing. Provide better care for your patients and be more efficient when you see your patients, because that would mean less out of pocket for the patients, the practice being able to earn more revenue per patient because they're billing correctly, and then also maintaining those patients in your practice when you're not a provider on their medical plan. That's real important, as our scope of practice throughout many states has changed. They have over about 100 procedures and 100 procedures and CPT codes and thousands of ICD-10 diagnoses that are included in their essential medical eye care benefits. Please look at the VSP manuals. Please join one of those webinars or a live event if they have them in your area, or talk to your state ambassador or VSP about that. 2 changes about VSP medically necessary. Contact lenses have also happened in the last year and a half. First of all, there have been increased reimbursements for high emmetropia patients. For example, you have patients in daily disposable contact lenses. Before, those reimbursements were hovering around the $700 range, but now they're around the $900, $950 range, depending whether it's sphere, toric, or multifocal. That's significant because, as many of you know, you have to provide a year's supply of contacts to those patients. And if you have them in a daily disposable, you could be shut out and actually lose money on that because that. You have to decide what contacts are going to fit those patients that the practice can at least maintain their profitability and do that. So VSP has actually increased those reimbursements on that. And that was due in part to the advocacy of the AOA. The AOA brought that up with VSP and they actually responded. It was in a provider email that VSP sent to providers, VSP Network News, at a glance in January of this year. That's how I found out about it. For keratoconics, another change that happened a little over a year ago for VSP, just for keratoconics and other medically necessary conditions, they must demonstrate a 2-line improvement over the best correction with glasses. So for example, you had a keratoconic with a 2025 that you improved to 2020 before a year and a half ago and VSP paid for it. If they're still improved to 2025 in glasses and they're only able to improve 1 line, that would not be covered under medically necessary contact lenses. But this only applies to the medically necessary and keratoconic conditions, not high ametropia, not that -10, that -11, or +12 patient you have in your practice. So it's really important to distinguish that. There are a lot of people getting confused and think they need the 2-line improvement on high ametropes, meaning the high myopes, the high hyperopes, that don't. They just need to be -10 or +10 and above to qualify for those high ametropia. There's no line improvement standard on that. Another thing that you guys may have been noticing in your practices, and it's real important that the practice owners and decision makers in your practice know that, is that there's been an increase in VSP Advantage plans in the last 3 years. Before, we'd only see maybe 1 or 2 a month. Looking at the latest VSP practice report in our practice in Colorado, it's about 5% of the VSP plans. These typically reimburse less on the exam than choice plans, but they use the choice plan copays for materials. Occasionally, there are outlier plans. For example, one of the nationwide ones that I saw was Common Spirit Health, which is a hospital chain. I know they're in Colorado and 6 or 7 other states, where their plan reimburses even a little bit less on the exam. You have the option, if you saw your VSP network news, to contact VSP within 90 days to opt out of that plan. Unfortunately, it's an opt-out, not an opt-in. I'd rather opt in personally, but it's an opt-out issue. So you need to make sure that you're able to make that decision which works best for your practice. If those differing reimbursements are not conducive to your practice and how you practice, you have the ability to opt out for some of those new plans. But in order to find out about it, you have to read the VSP network news. They reach out to you via email. Those VSP updates are sent on a monthly basis with the subject of VSP Vision News for VSP providers. And then in the body of the email, the title is called At a Glance. So you have to look. It's in blue. Some of the important stuff is in blue off to the right or in the body of the email. In the body of the email off to the right or other places. Next, I wanted to talk about IMED. IMED's a little bit different on how they do that, but IMED does have updates. IMED's updates can happen at any time. When they changed their medically necessary contact lens update, they changed it in June of 2024 also, actually. It wasn't at the 6-month mark. It was at the at the beginning of the 6th month, not at the half year. Usually it's July 1st and January 1st where they make their updates. But the medically necessary update for their contact lenses, making sure that you're meeting those medically necessary requirements, require a prior review where you have to send the charts and they have to have the components of the exam that are pertinent to medically necessary contact lenses. For example, topography, showing Ks if you have pachymetry, your keratometry must be on that if you're doing keratoconic, visual improvement, scarring claims for your patients. And IMED has to send those charts in. You have to send those charts into IMED and get those quote unquote approved. They don't like to call it a prior authorization. I think it's a semantics. I think it is a prior authorization, personally and off the record, but off the record with 100 of my friends here. But I want you to understand that. IMED also sends network news updates to providers. They will send it in November, December, like for the January, and they'll send some in July too. If they have new groups, changes to the formularies that they use on the lenses, changes to new plans and new larger groups in your area, you can check that. But what's nice also on IMED has a whole provider website called IMED in Focus. That's the provider website. You can either reach it directly on imedinfocus.com, or you could go through the provider, the IMED claim website, and then on the lower left-hand side, it says provider resources. You can click on the link there for the provider website to read your contract, your reimbursements. You could read the news, the network news updates that you've been having for the past, the archive of those for the past couple of years. You can also see special exceptions for different plans. For example, IMED has a different exception, different criteria for Humana for medically necessary contact lenses, where you need a prior authorization and sent to Humana. And it's not billed like IMED is billed. You have to submit the receipts or the cost of those lenses, and then you're able to actually bill every follow-up visit, where you normally, we're used to like putting it all together in a block, right, and getting one just reimbursement. For the Humana medically necessary with IMED, you have to actually bill every follow-up visit in order to make it with your patient. That's how that medical insurance works with that. The website also allows you to add additional staff. This is one advantage a little bit, is that the iMeds in Focus website also allows you to add additional staff to get email notification. So you have the staff that's able to get email notification, and not just the owner, but like your managers or your opticians or whatever, and you can pick how you want to get the email notifications. I think that's one thing that does give us a little bit of an advantage. Refraction only claims and coordination of benefits with IMED. I know I spoke about this more in detail in April, but I wanted to kind of talk to you after talking with some heads of IMED last month at Optometry's meeting. There are more and more plans. Approximately 20% of IMED's total membership has refraction only claim benefits. Now, it used to be 100% before 2018, but now it's but they were, to quote IMED, they're erroneously paying these claims when they shouldn't have, because they didn't have the functionality of their claims processing system. But the way you look at it, who has these refraction only benefits, and how do I submit that? Well, they have a list. They actually have a whole form on their website on coordination of benefits. It's in the provider manual. Plus, they have a three-page sheet that tells you how to do it and which plans qualify. And you're able to coordinate the refraction, pretty much, a refraction only claim, up to what IMED's allowable is for that claim. For example, if the patient has a $0 copay and IMED reimburses $45, they'll reimburse up to $45 towards that refraction. If your refraction's less, they'll reimburse less. It's kind of good because the current list of member groups includes Cigna Commercial, Anthem Blue Cross Blue Shield, AT&T, Humana VCP, and many more. I'm not going to go over the complete list because there are about 80 groups on there right now. Devoted Healthcare is another one. I'm sorry, someone's not on mute.
Happy birthday.
So that's one thing you have to just understand. That. One thing that's a little bit interesting, we're noticing certain Cigna claims are automatically being forwarded to IMED. When you build Cigna Medical, it's being forwarded to IMED directly from Cigna. So that's the first time I've seen that with a vision plan and a medical plan doing that. But it may be a sign of things to come. That's not a bad thing. It just saves time for the office instead of having to submit that claim again. Because with IMED, you have to submit it electronically or by fax to them. By fax. Eventually, they're looking at ways to make that more efficient, because right now with IMED, it's not that efficient because you have to fax in paper to do that. Rumor has it they'll be able to scan stuff, or looking at other ways to make that efficient. With VSP, it's all done on its website. You're basically attesting on the website and adding that when you're coordinating benefits between the medical and the vision plan. One really important thing that providers don't seem to that have a hiccup with IMED is credentialing and recredentialing, specifically recredentialing. IMED follows a strict interpretation with regards to recredentialing providers. It is important with IMED and actually every other medical insurance and vision plan for providers to attest, meaning optometrists or ophthalmologists in your practice, to attest and keep their CAQH profiles updated every 120 days. Pretty much every provider is on CAQH. What it is, it's a portal that makes credentialing easier for all the medical plans. And they have to attest and update their latest license, their latest malpractice insurance, liability insurance, their, where they're seeing patients. And that needs to be updated every 120 days and attested. Sometimes you don't have anything else to upload during that time. You just need to attest that that information is correct. And also that directory information is correct. So the important thing with that is with IMED, if you're not attested and you're not current on your CAQH, and after you get several notices, IMED will terminate you. Also, I've seen providers terminate from United Healthcare and other insurances for not recredentialing correctly and keeping their CAQH updated. That is a means to get terminated from the panel. The challenge is getting back on that panel. It takes 120 days for IMED to recredential a provider. That's up to 4 months where you're not able to see patients. If your practice is dependent on IMED, or if your practice is dependent on United Healthcare on a separate issue, trying to get back on, it's frustrating. And you can't see those patients because you're considered out of network. So I implore everyone to make sure, check those CAQH emails coming to your providers, or if they're coming to the office email, make sure that those providers are attesting every 120 days and responding to those emails, requests, whether it's through IMED, through CAQH, or sometimes division plans use a third company called Gemini to tell you to update your CAQH. And then Gemini goes in and sucks that data out and gives it to IMED. They act as like an intermediary between some of the vision plans and CAQH. No one wants to be terminated when they don't, because that could certainly affect your business. Frustrated patients, frustrated providers, not a good thing. Well, the next thing I was going to talk about is audits. I didn't know which meme to use in getting this lecture, but you get the picture. We all have that face when we receive an audit letter. Not fun. But sometimes it feels like, especially lately, if you're on the social media groups or you talk to your friends in other practices, that everyone's getting audited. You get an audit, everyone gets an audit. And it's like Oprah giving out cars on her TV show. And audits are very stressful for practices, can be, especially if you don't know what kind of audit. If you think of all audits as the same, that can be stressful because you're like, okay, did we do things right? Are we complying? Are we, did we complete that chart like we should? All the providers should always look over the charts before they send a chart that's audited back to whoever the requester is. Because you want to make sure if you need to add an addendum to that chart. I'm not saying change a chart, add in an addendum. That's the HIPAA compliant way. You can't change the chart once it's already made, but you can add addendums to update changes, or if you forgot to put your plan, you can add that in as an addendum on most EMRs, or if you're on paper or whatever, add it on paper and sign and date it. There are different types of audits and optometric offices. I discussed a little bit of this, but I'm going a little bit more in depth in a different way here because of things have changed really in the past 3 months with audits. The most common types of audits in the optometric offices are really the medical record audits or the financial audits, okay? They happen with both the vision care plans and the medical insurance plans. Those audits, some of them are routine, some of them are targeted. The routine ones typically you see from vision plans are the 10 charts along with the financial records, sending it there to IMED seems to be the most one that does that. VSP is really, in my opinion, since the pandemic has really been going through the targeted audit avenue where they're concerned about something or a patient complained about something. Audit's going to happen because it could be just common, just making sure that your practice is doing everything it says it does. That's usually a 10 chart audit with a new provider, a relatively new provider. There's a patient complaint. That's usually a single chart, that IMED or VSP is asking you to send over to make sure that you charge the patient correctly, that you did something there, and some of the patient complaints, frankly, are without merit. I had a patient complain to our office about Medicare one time not covering glasses. Well, he didn't qualify for a Medicare DME for glasses, and Medicare doesn't cover glasses, and he thought I was taking advantage of him. When we strictly told him that's not a covered benefit under strict Medicare unless he had surgery or a few other conditions. This patient did not have that, and we're not a Medicare DME provider in our office anyway. So the auditor I even spoke to the auditor on the phone or whoever was asking. They're like, "Don't worry about it. You're fine." He was just confused. I said, "Okay," but I sent the information in as requested. Nothing ever happened. If you do things right, so you can sleep at night if you're a provider, or your provider does it right, or you run a tight ship. You do it right the first time, do it right in the beginning for every patient. Your risks of having issues during audits are truly minimized. You just want to make sure you're following the rules of all the plans, whether it's coding correctly, whether it's ordering the correct amount of tests and the right frequency for tests, or explaining why your frequency is a little bit more. Another things that, these medical plans and vision care plans will also look, are you at the statistical norm for providers? Meaning, a normal provider may do 3 amniotic membranes a month, but your office does 50. Well, that's not in the statistical norm, isn't it? And so you have to you have to explain why, which you could be an outlier for a perfectly good reason. B, you could, why are you doing this more than everyone else? And they can recoup the money, and it could lead to, fines and sanctions with like Medicare, or be kicked off or having to reimburse. So it's real important to understand that, the different types of audits. There is a third one. There are facility audits. I've only seen it in a vision care plan with the IMED. Actually, we had one for a new provider, and then they wanted to take pictures of our facility. Or no, they wanted me to take pictures of our facility to make sure we had a slit lamp. And then we had to attest that we had, did we have a sharps container? Did we have a first aid kit? They wanted to see pictures of our rooms and equipment, so we uploaded that up to IMED. They also want to make sure my staff was dressed neatly. I thought that was a fun one. So I said, staff, make sure everyone's dressed nice. No, I didn't know if I was supposed to take a picture of my staff or not. I thought that one was a little interesting. What am I going to say? No, my staff's dressed like slobs. Thankfully, my staff is dressed nice with, they have, we kind of have those standards in our office. But that one was a remote one where we had to send photos and attest to the facility, meaning like we had our hours up, our certificate of business and license, and etc. So, and we had all that, so that wasn't a big issue, because the reason why is when I joined the network, I saw those requirements in the beginning. I read the provider manual. So if you read the provider manual of what they want, sometimes as ridiculous as it can feel sometimes, the stress is less. For those of you who do VA disability exams, not just the community care regular exams, but disability exams, there are about 4 or 5 contractors throughout the U.S. A couple of them are QTC, Optum, etc. They'll come out and look at your office every year to make sure you're a real office. They want to make sure you have a sign up that has a veterans helpline, because you're seeing veterans in your office if they're having mental health or other issues. They want to see that you have a fire extinguisher. They asked where my fire extinguisher was, but our local code actually says we don't need a fire extinguisher when we build our building, because our building is like 12 years old. We have a sprinkler system. Luckily, we still had a fire extinguisher, and she's like, well, where's your sign above it? I'm like, we have a sprinkler system. So sometimes it feels silly, but if you explain yourself, it's fine. So they just want to make sure. And then she asked if I had a slit lamp. I said, well, we have 6 of them in this office. Do you want to see that? But that was actually an on-site visit. They want to make sure the office is tidy, that you are who you say you are, because, fraud, waste, and abuse for the government is a real thing. This even happened before the whole Doge stuff earlier in the year. Government really is trying to reduce fraud, waste, and abuse from VA, TRICARE, Medicare, and Medicaid contractors. So it's real important that you have your ducks in a row, office in a presentable manner and just meeting their requirements. A new kind of audit, which I really wanted to discuss with y'all, was the risk adjustment audits. This is the one that's been kind of blowing up lately. If you may see on your social media, these are data validation audits on Medicare Advantage plans by CMS to verify the accuracy of those diagnosis codes submitted by the plans to Medicare for risk adjustment. You notice I said plans to Medicare. Well, how are the plans going to do that? They're going to ask us for the records. These are specifically Medicare Advantage plans. Think of Anthem Blue Cross Blue Shield, Humana Medicare Advantage. Any other, all Medicare Advantage plans have to kind of comply and send this information in. And it's been frustrating because I know offices have had over 700 records requested by these Medicare Advantage plans or their proxies. And that's a lot of time on the staff. I'll come back and talk to that. Actually, these risk adjustment audits, I just got the slides out of order here, but I'll go back to the other slide in a minute, create a significant burden on our practices. Some practices that I know have had over 800 charts requested. We just had 82 charts requested from Humana in my office. The AOA wrote an article on June 25th from the third-party executive committee chair talking about strategies that your office can do to comply. First of all, you can call or email the requester and ask them for an extension. But you also have to understand that, when you have 800 records or 82 charts and stuff, they want the full charts for that calendar year for each of those patients. So if you saw that patient 3 or 4 times, they're a glaucoma patient, a diabetic, or a patient, AMD patient that you see multiple times a year for different reasons, whatever it is, that's a lot of charts. They can have you upload it or mail it. That costs a lot of money. You need to charge for your office's staff time. There are stories out there that offices are asking up to $50 per record and getting paid for it. You have to do what's good for you. They do create a significant burden on the practice, though. These chart requests and stuff like that for these risk adjustment audits. These risk adjustment audits are not a financial audit, whether you did the work or not. It's okay. You saw a patient with this Medicare Advantage plan. You coded it. You got paid for it. Now they want to see the chart to see if they got all the codes correct there, that you coded correctly. And then they review that or have a third party look at that to comply with their Medicare CMS audit, the CMS risk adjustment audit that the plans are getting. And this affects their star rating. What are star ratings? Star ratings are when, for Medicare Advantage plans, talking about how compliant they are and how good are they doing at reducing costs, making sure their patients are getting the care that they should. So a plan with a lower star rating may not be able to provide Medicare Advantage plans. So it's real important for these plans to get that information, but you're allowed to charge for your time for that. Other charts requests, basically you have the patient could always request their chart. We usually refer them to a portal in our practice. Law firms can do it, not just for you, meaning like, it could be because they had a car accident somewhere else. Or they had, they're requesting all their medical records for Social Security or disability. Law firms can do it. The state can do it. The state of Colorado, where I'm at, does it for disability claims. Social Security can ask for it. And you're allowed to charge them by that. Though what you can charge and what you can do to those for whether it's a law firm or Social Security or disability varies by state of what you can charge them for. This is a check with your state because it does vary. Every state's different. Just Google it to see what your maximum charge per page is in your state or per clients. Many states have caps on what you can do for that. So it's not like you're going to get rich on them. Sometimes it's $25 or $35 for that chart. If it's only a 5-page chart, it may just be like $6. But there's time and effort with your staff to gather all that stuff together and make sure it's accurate and complete. Make sure you send an accurate, complete, and full chart to the requester, though, whether it includes images, special testing, OCTs, visual fields, topographies, etc. Make sure you send all that information. With regards to that risk analysis, going back there, one last thing I wanted to mention is you don't always see the letter Humana on there, the name Humana. They may use a company like Cotiviti. Cotiviti is their vendor that gathers all this information for the plan. These are 6 of the largest vendors for these audit risks and risk adjustment analytics. So many times you'll be like saying you're not sending it to the Anthem office downtown. You're sending it to this Cotiviti or Edifex or et cetera, Veridime, whatever it is. So if you're wondering what those companies do, that's what they do. One last thing I wanted to check on today was language assist. Wanted just to talk about is language assistance services. This is getting to be as clear as mud, but I wanted to give you a little bit about it. Okay. All medical insurance companies provide language assistance services to providers. Some require members to submit the request. Some others allow the provider to submit the request. Go on your United Healthcare, your Anthem Blue Cross, your Cigna, your Humana websites to see what they do. There's a process where you can call. You probably have to do it in advance. You can't just call and expect an interpreter there if the patient just walks in off the street. VSP and IMED also allow for language assistance services. You have to, I know on IMED you have to call, or the patient calls ahead of time for like translation, and there are specific protocols to do that, and VSP also has that also. What I'm unclear on, I have some messages out, and I hope they had, I wish I had this before our discussion today of whether it includes American Sign Language. That's been the challenge for a lot of practices. Actually, you can't deny a person those services, or they have a right to interpreter for their healthcare. And a lot of times, especially if it's a routine eye exam or even just an E&M code for medical, you're paying more for that interpreter there that's in the office than you're getting reimbursed for the whole thing. So when the plans do allow it and you're billing medical or whatever, take advantage of that. Inquire about that locally with the plans you are on to see either A, you get reimbursed, or they may be able to provide you with a virtual interpreter or virtual American Sign Language, like using an iPad in the office. We've done that in our office before, having iPads with contracting with an outside service. So we don't have to have the interpreter in the office, and that suffices as being compliant. But confirm with each insurance company before providing those services. State laws vary on what type of services an office must provide, may vary a little bit by state. That's more in the language, like you have someone who speaks a foreign language. But the federal is, you have the Federal American with Disabilities Act for like American Sign Language. So it comes under 2 statutes. For example, California and Oregon statutes are a lot different than Idaho's, Colorado's, or Pennsylvania's. Medicaid in certain circumstances, I should qualify that, does cover the cost of some of these services. Please refer to your state Medicaid plan for more information. I think in Colorado, it's like only in the rural areas, but where it may be harder to get an on-site interpreter, but others, sometimes they do pay for that. There are commercial interpreting services available because you can't discriminate against your sign language patients who communicate through American Sign Language. 2 of them are purplelanguageservices.us or genie.com. Just make sure it's HIPAA compliant and making sure that you're able to provide the services for those patients. And you can use we do it by having an iPad in the room, and that really helps out. And then we have a contract with one of those. And then, they provide you like so many minutes free, and then you pay like $3 a minute above that. Depending on what plan you're using and how often you see hearing impaired patients. Well, that was kind of what I had today. I hope that explained that to you. If you certainly have some questions, you can. We have a little time here, and I may even have. I also have a staff member here to help me because she kind of handles the nuts and bolts of some of this in our office to be able to do that. But I hope that was informative to everyone today. Thank you.
That was great, Dr. Ortman. You have a lot of great information to share, most definitely. We did have several questions come in through the chat box, so I'm going to kind of read them to you in order. And some of them I think were answered through the next session, through the next slides, but some may need some touchback. So the first is around IMED and medically necessary contacts. The ask is the prior auth for IMED for medically necessary contact lenses for all IMED plans or only Humana IMED plans like that are specific? Their biller was under the impression that it's only required for specific plans, but when they recently called for clarification, they were told no prior auth was needed.
So, okay, I'm going to put this in two buckets. First, let's talk about most IMED plans and not Humana. Most IMED plans, as of June of 2024, you have to submit for medically necessary contact lens reimbursement before you submit the claim or with the claim. You have to submit your chart indicating with the correct diagnosis, the patient has keratoconus, the patient has pellucid.
Right.
You also have to submit and what's the proof of that? Your slit lamp exam, your topography or keratometry, your showing the improvement of 2 lines over glasses before they'll pay for that. For that complete list, which I did not give you the complete list, but you could go on IMED's provider in focus. It has a form of what you submit and what you need to submit to be compliant with that.
Okay.
With regards to that, Humana has a different form. You don't submit to Humana directly to IMED. Humana has a different form on IMED's website because Humana and Humana Vision use IMED, but Humana approves the medically necessary contact lens benefit. And that's the one where I say you can charge for each of the follow-up visits separately because Humana thinks like a medical insurance and not like a vision plan on this. So in order to do that, you submit a prior authorization to Humana, and IMED has that prior authorization form on its website. And they want to know the cost. They want to know, how it qualifies according to Humana's thing, and it's all on that form there. Look under forms under the provider in focus website under medically necessary contact lenses. You'll see that there.
Okay.
Does that make sense? I hope that answers the question.
Does that make sense? It was Amy that came in from, but a few others had some questions similar to that.
Yeah.
Um,
Yeah. So, okay. I saw one here from Kelly and Julia that our billing specialist was instructed by IMED to contact them to confirm each time as plans can vary. One thing I've noticed that if IMED has a medically necessary on the bottom, it's usually right on the they don't call an authorization on the patient form, relates to the authorization. It shows the benefits, right? And are they eligible for the exam, the contacts, the frame and lens, right? At the bottom, if they do have medically necessary benefits, it usually says it at the bottom of the form there under the contact lenses. But if you want to be sure, you can call them ahead of time and confirm. We usually only do that if it's something irregular that we don't normally see in our office.
okay. The other questions that I'm receiving are coming in from the audits. One is with all the fraud out there, particularly the Medicare fraud going on, asking for charts. What's the best way to differentiate a real audit versus a fraud attack?
Well, that's great. A real audit from a health insurance company. That's why I kind of gave those names of those companies there on that. But also, you can email them first before you email them or call the phone number. There, a lot of time we emailed and there was a direct local number for our Humana office in Colorado. When I saw 82 charts, I wanted to make sure that I was sending it to the right place. That they have a portal that, and everything like that. On an audit on those Medicare risk assessment audits for Medicare Advantage, they're not asking for the financial information of that patient or the demographic, like your whole demographic of the patient's age, phone number, insurance cards and stuff. They really just want the chart. And they have a portal set up for that. But do your homework and check it out and confirm either maybe not on that test, but your provider representative or contracting representative from that insurance company to make sure it's not a fraud. Fraud stuff usually have goofy emails. if it says like onehumana.com or like a Gmail address that's asking for this information, that'd be, or a Yahoo or whatever it is, that may be fraud. See who those emails are from. It's like looking at the emails, everything that you get in your everyday. The ones that we got were faxed in to us from Humana and from Anthem Blue Cross Blue Shield for our risk adjustment audits. And it looked pretty, it pretty looked official. The logos, everything was the same, and it was a patient, and all the stuff there was very similar, and it had a local phone number of someone that we knew of from Anthem Blue Cross Blue Shield.
Wow. Wow. We do have a lot of chatter about getting paid for the risk adjustment audits. Sam indicated that they do charge 25 to 35 per chart. And just for anybody that hasn't seen the chat, there's discussion about how to get reimbursed for that and sending them an invoice. And several members have indicated that, yes, they have been reimbursed for this by submitting it on an invoice with a W-9.
Right. They're going to want a W-9. And that's normal. A W-9 is just your tax form because they're paying money out to you. So they need a tax form. And you're like, well, Anthem already has my tax form. Remember, they're using these third-party companies like Cotiviti, stuff like that to do this. So they're the ones cutting the checks. But what we did in order to make sure that they're going to reimburse it before we submitted the information is we replied to it had someone's email from Humana there. We said, hey, listen, this is a burden on us. We're a small office. I don't have the ability to put together 82 charts. My staff's ability to do 82 charts on all these patients and have all that information readily and available is going to take days. There's a cost associated with that. And we told them what our cost per chart was. They said, send that to us on an invoice with a W-9. They approved it. Once we got the check, we submitted all those charts. It worked.
Oh, that's great. That's great. We do have a follow-up question about the Humana plans with medically necessary contacts, where it sounds like they are not reimbursing the lens fees. Is that correct, Lisa? Feel free to unmute. I want to make sure I get your question answered correctly for you. She had asked, how do we handle medically necessary iMed patients when the reimbursement doesn't cover the lens fee or the fitting? That they really are in the red just with the lens fee alone. And that someone did make a comment that Humana does have a max payout of $500.
Right. And that's for the lens fee and maybe the CPT code for the fit. But unlike the regular rest of iMed, you're able to build a follow-up visits. I don't know, Shayla, are you able to chime in on that?
Yeah, so on the Humana plans, they only pay for the initial fitting and the first supply, supply of contacts. So if they're dailies, they're only gonna supply or pay for a 90 pack per eye. And when Humana is one of the ones that you have to do the prior auth for. And when you send in all of it and they approve it, they will send you a fax or via mail an allowance that they will approve. And then after that initial supply, you are able to bill the patient for the rest of the lenses. That's why that one is so low.
And you can, if you look back at the old CPT codes for scleral lenses and Gazprom lenses, you can charge for modifications. You could charge for each follow-up visit that patient comes in, like a 99 an E&M code, whether it's a 99213 or 212.
Okay, we're in California, and our Humana pre-auth form specifically states that the $700 allowance includes the lenses for the annual supply and the fitting. So it's virtually impossible to get an annual supply and a fitting and make $1 on that.
Right. You don't. There are lenses that you wouldn't fit on there, right? Why would you fit a year supply daily disposables where your cost is $700 or more? Right. You couldn't do that for that patient. You'd be like, I can't fit you in that lens. Your insurance doesn't cover that.
So when we submit this this authorization form, they process our claim right off of the auth form. So are we able to tell the patient up front that their insurance does not cover their annual supply because it's over what they pay? Because they make it sound like you can't turn a patient away for that just because you're, going to be in the red. You'll make this, like DSP tells me all the time, you make some on some people, you lose some on some people. It all comes out in the wash.
In my opinion, you choose what lenses are covered by which plan. And if the patient wants to go out of it on a cash pay, you got to follow it with your supply. So for example, doing daily disposables, toric on early keratoconic, where the daily disposables cost $1,200 a year, you may have to go for that patient to a monthly disposable.
Mm-hmm.
That's what's going to have to happen. He's just going to do that.
Because you're not in the practice is not in the business to lose money on this.
Right.
All right,
So,
guys.
And the vision plans recognize this, by the way. But for example, ActView Oasis 1-day max multifocal is going to be like $1,500 a year. iMed actually doesn't cover multifocals in medically necessary contact lenses. BSP does. So go figure. That was another change they did in June of 2024.
That is all the questions that I'm seeing in the chat box right now. I do have a few opportunities that I want to review with everybody before everyone jumps off. So I believe that's it for the questions. So I'm going to move into that part. First of all, for exclusive opportunities for our Opti-Port members and our PERC P3 study group members that are on the call today, we will be having a meeting at our Spark meeting at Vision Expo West. We have a very thoughtfully crafted agenda for our meeting. Our theme this year is disruption, and we'll be walking through different aspects of your business affected by disruption, like technology and culture and people. So please take a moment and scan the QR code here on the left to learn more about the Spark meeting on September 17th in Las Vegas from 8 to 4:30, as well as our reception that evening from 6 to 8 p.m. at Tau. Now, for our PERC members that are on the call that are not part of the P3 study group, we do have a few remaining seats in our information session with our PERC P3 study group team and the I Promise team. You'll get to go for a spin on the high roller Ferris wheel and learn more about how PERC P3 study groups will help you grow your practice. So for information on that, please scan the QR code here on the right and answer a few quick questions to show your interest. That will take place on September 18th at 6:30 p.m. in Las Vegas. Now, for anyone who's not attending in Las Vegas, not going to Vision Expo West, but are interested in learning more about these study groups, visit our website, perkalliance.com. And under the programs tab, just click on P3 study groups, and then it'll direct you from there on how you can get in touch with our team. So exclusive opportunity that I do have for our Opti-Port members on the call. Opti-Port's exploring the opportunity for an ABO prep course. This would be powered through our Opti-Port learning platform that's powered by Leonardo. The course would feature a live instructor, be tailored to help your team succeed. So if you're interested, take a quick moment, scan this QR code so we know about that. So last but not least is the survey, guys. It came to you via email. Please take a quick moment and fill that out. We love to keep bringing you additional value with every one of these sessions. So we definitely review your feedback and select our upcoming topics based on that. So that's all we have for you today, guys. Thanks so much for an awesome day, and we look forward to seeing you soon.